So we're going to talk about the balance and coordination impairment comp today. So when we did this comp traditionally on campus and we had, you know, all of you guys and you had all semester to do it, what I did was I gave you each a scenario that you started with at the very beginning of the semester, and then you worked through that scenario for the entire semester. Well, it doesn't work very well here virtually. So we're going to kind of go over this together and walk through it. One of the things you guys need to start getting really good at, and I know some of you are doing it, but you guys need to get better about doing it, is verifying your patient. So we're going to walk through the first part of it, right? With the balanced patient, it is extremely, extremely, extremely important to have all of your equipment before you start treatment. Why do I say that? Well, if you have a balanced patient, you can't just let that patient sit at the edge of the bed while you run and grab a foam roller or a foam pad or something to that effect. Okay, so it's really important that when you go into that treatment room, you have everything you need so that you can go straight into that treatment. The other reason for that is with these patients, they're going to fatigue often very quickly. So the longer time you take to do this treatment with the patient, the worse their balance is going to get. So you need to be prepared. Like this organized all treatment, all equipment and stuff like that. This is probably more important for these patients and for the neurological gait patients than it is for anybody. You have to make sure you are prepared to treat your patient. So what type of conditions are you going to encounter that you're going to be doing balance treatment with patients? What type of neurological conditions? Stroke, good. That's a big one. SCIs, yeah, right. Vestibular is a big one. There's our big one, right? MIs, yeah. I mean, when you look at it, pretty much any patient, because we could just say anyone 65 and older, couldn't we? Because I bet if we went out and grabbed, 25 people that are 65 or older, Guillain-Barré is a big one. Yeah, thank you. Right. Or as as one of my patients was called, I got that Guillain-Barré disease. Right. Any of those patients, pretty much anyone 65 or older, I bet, as I said, if we get 25, I'd be willing to bet 20 of them have balance issues. I have no scientific research behind that other than just experience. So it's going to be big. Even kids, right? A lot of the kids that I treat that have, kids that are diagnosed with CP, that are diagnosed with spinal, what do you call it? Oh my God, SMA, stuff like that. All of them, you're going to need to do some balance training with them. Yeah, that's right. When you get to an older person and even kids, they don't know that they have a balance problem, right? They just think it's normal for them to fall. So going in to treat them, and I know I haven't hit this very hard this semester, but I want to make sure I hit it. If you're in the hospital, please, you have to foam in before you go into the room. You have to wash your hands and you have to foam out when you leave the room. That is a JACO rule, right? If you guys know who JACO is, who is JACO? I'm hoping Dr. Sokel hits that with you guys. JHACO, the Joint Commission. Good, right? They're the group that basically makes sure that hospitals are following the rules, right? How do you know JACO's in the hospital? When you hear the nurses hiding their water bottles. Because we can't have water bottles on any desks when, the silly, that's the one thing that JACO's worried about more than anything is, are there water bottles on desks? I don't understand that, but whatever. But JACO requires you to foam into the room. Paper's not in plastic covers, exactly. Everyone does freak out. They call it code white over the radio is kind of common. Code white usually means states in the building. Code white means a couple other things, other hospitals too, but usually code white means states in the building. Or JACO. State or JACO, doesn't really matter. They pretty much rule the same. So you need to foam in when you walk through the room. So that's when you just kind of foam, right? And then wash your hands once you get into the room, and then you're going to foam when you come out. They will nail you on this. So please don't skimp out on that. Honestly, when I introduce my patients to myself to my patients in the hospital, I'm usually either doing it while I'm washing my hands or as I go into to meet, hi, my name is Keith. I'm your physical therapist assistant today. I just want to let you know, I just washed my hands before I came in here. I let them know, because one of the things on the patient's survey, when they get a survey, and you guys probably don't know this because you may not have gotten one of these, but one of the first questions is, did your provider regularly wash their hands? And most patients are going to go, I don't know. And so they'll either put NA or they'll put no, right? So it's kind of important to make sure that you tell them, because if you tell them, they're more likely to remember that you did. So I'm going to come in and introduce myself. Hi, my name's Keith. I'm your physical therapist assistant today. Today, we're going to do some balance work, right? It's going to involve getting up, getting down, doing a little bit of fun stuff like that. Yes, hand sanitizer. I'm sorry, Anthony. Yes, hand sanitizer. Foam in means you hit the hand sanitizer foam. They know what we're going to do. Is it okay if we treat you? In the hospital, the next thing we have to do, you guys are getting really good at this with Dr. Reston's comp, and I want it to get even better, is to do what to the patient? Verify that you're treating the right patient. We got consent already. We'll say we already got it. Verify you're treating the right patient. How do you verify that you're treating the right patient? Yeah, name and date of birth. I also don't just trust name and date of birth. I check the wristband. You're 100% correct, Kelly. As I'm checking the wristband, can you verify your name and can you verify your date of birth? That actually validates 2 of those alert and oriented. See? One of our PMO students. Do we have students out on rotation? That seems weird. I don't think we have anyone out, but okay, I'll trust you on that. I hope it's one of the graduates. Okay, good. Yeah, right? Yeah, always verify. So there, Kaylee has an excellent example. Make sure you verify you're treating the right patient, right? Don't. And honestly, I'm going to be honest, I've done that before. I've gone through a whole treatment session where the guy says nothing to me. And he's like, I was so glad to have my first visit from physical therapy. I'm like, oh God. Right? Don't do that. Just verify, right? So along those lines with the alert and oriented, right? We have alert and oriented ×3 and ×4. Alert and oriented ×3 is person, place, and time, right? Can you verify your name? Do you know where you are right now? Do you know the day, the date? Their birth date counts as time. And then there's the 4th one that you can verify, which is the abstract. Tattoo is a valid, yeah. The tattoo is a valid, yeah. I think that's a fantastic. That's a valid, whatever. Yeah. Can I see your tattoos, please? Sure. No, not that one. What color is an orange? Who drives the Batmobile? We used to every time go, who's the president of the United States? That was the big one we used as long as I can remember. We don't say that anymore. Just don't. It usually does not end well. I'm just telling you, you will spend 15 minutes on that question alone with some people. Just imagine coming in and asking a confused and angry Mr. McKeever who the president of the United States is right now. And imagine how that would go. That should tell you not to do it. For 45 minutes, you'd get a far left diatribe from me. All right. So we get to balance. What are some contraindications to treating a patient with balance? What do you think? Okay, lightheaded, severe lightheadedness. Good. What's that? What's the medical term for lightheadedness? Feeling syncope, right? Or vertigo. We'll talk about, yeah. Syncope is lightheadedness. Vertigo we'll talk about is the spinning, right? That's, yeah. Oh boy, I'm feeling a little funny, right? Any new recent falls, right? Could be a contraindication, right? We just want to make sure we document it if nothing else. What's our big one for almost all of our treatments? What's our big contraindication? Well, cancer could be, not for this one so much. Unstable fracture, good, right? Especially if they've had a fall and we've got a new fracture. when they are in the hospital, right? Even when you're seeing a balanced patient, it doesn't matter what your treatment is here, whether it's balanced patient, whether it's just a general illness patient, you have to know their status. Meaning, if I'm seeing a patient in the ICU today, and now they move up to the gen med floor, do I need to get a re-eval on that patient? No. If they improve in level of care, if they go from ICU to just the general medicine floor, we don't have to get an eval because that's considered an improvement in status or a slide up in status. Now, if they go from gen med and go to ICU, now we have to get a re-eval. Does that make sense? Do you see the difference there? So, if they get better is a good way of thinking. If they get better and are on a lower level of care, we don't need to necessarily re-eval them. Would it be a good idea? Probably would be a really good idea because the patient has maybe had a little bit of change of status. But we don't have to necessarily re-eval them when they move from ICU out to a gen med floor, out to an ortho floor, or out to a neuro floor, or out to a cardio floor. If they go, so let's say they're in a cardiac ward and they go from cardiac to cardiac critical care. Now that is a decline in status. That requires a new eval. So let's talk about that. How do we get a new eval for that patient in the hospital? What has to happen? Yeah, but how do we get it? How do we physically actually get them get a new eval? Who do we have to talk to? Yeah, tell the doctor, right? Or the nurse. Either one of those, right? And what we have to do is we have to go in, let's say we had, let's say that Renee is my patient and she was out on, she was having a ACL injury repaired. And then all of a sudden she got septic and is now in the ICU. I have to go verify that she's in the ICU as the PTA. Then I have to go into her specific chart and document that I am canceling treatment due to a decline in status. Then I have to find the nurse or the doctor and I have to have them order a new PT eval. That new PT eval in the EMR, the electronic health record, EHR, whatever you want to call it, will cancel the old eval. And that'll get sent then to the PT to be done. But you have to have this done. If you just say, oh, well, they declined in status, hopefully they'll send up a new eval. There'll never be a new eval and you'll get, 2 days later, the nurses are trying to figure out why we're not seeing that patient anymore. And nurses don't understand this. So it's really important that we educate them that when they have a decline in status, it requires a new eval. So let's say we have Joe, the Parkinson's patient, right? He's up on the floor. He's doing really well. We've been working with him for a few days. He's getting ready for discharge. Well, then Joe decides, oh, well, I'm good enough to get up to go to the bathroom by myself. And Joe looks at his walker and it's all the way across the room on the wall and is like, well, I don't really need my walker. I should be able to get to the bathroom by myself. He gets to the bathroom, goes down on the toilet, falls, and cracks his head off the wall. Now has a split open skull, and he gets sent to a higher level of care. At that point, Joe needs to have a re-eval. Now, if Joe cracks his head and is still in the same level of care, everything's stable, he just bumped his head, we may not necessarily need a re-eval, but that's going to depend upon what nursing says, what his cognitive level is and stuff like that. We may want to get one just to be safe. We don't necessarily need that. If he changes and declines the status, if he has the new fracture, new blood clot, gets transferred to the ICU, if he goes from gen med to, say, the cardiac wing, that's a decline in status, right? Normally, the gen med floor is called med surge in most hospitals. medical surgical floor, right? That includes everybody, right? What would be a decline in status? Well, going from med surg to cardiac care unit, going from med surg to neuro care unit, going from med surg to the cancer wing. Those would all be a decline in status. Those would all require a new evaluation, or at least a reevaluation technically is what it is, more than new evaluation. Again, the doctors, the nurses don't understand that, but we have to be cognizantly aware of that. And they're going to want, well, you know, I know that Joe needs a re-eval. I know that he came down to the ICU last night, but can you at least get him up and get him out to the chair? What do you say then? Yeah, no. Now Sarah is the nurse that you really kind of, you're taking a shine to her. She's a really kind of nice nurse. She's been so good to you. She helps you every time you come down to the ICU. And she's like, okay, I understand that you can't get them out to the chair, but can you come in and help me get them out to the chair? Just be there as an extra set of hands. What do you say? Yeah, no. Why would you say no to that? It's a setup, right? Admiral Akbar has a really good phrase for that. It's a trap. Right? Yeah, liability concerns, because here's the deal. Sarah may be your best buddy, and you really take a shine to Sarah, and then the patient falls. Sarah's going to say you were the one transferring him. I know that we all want to think that everyone's the nicest person in the whole wide world, but they're not. Right? That's one where you have to say, unfortunately, because of the rules governing my license, I can't do this right now. Now, let's change that up, right? So now we see Kaylee, and Kaylee is working as more of an assistant, not a PTA, but as a nursing assistant or whatever. And we're going by the room, and we see Kaylee's getting a patient out to the chair, and Kaylee is struggling, and the patient's about to fall. What do? Just walk by like nothing's happening? Yeah, help them. Right? If it's a difference between a patient falling and not falling, help them, right? Just be aware of that. There's that really fine line you have to work on. And Kelly's exactly right. I would not get that patient out to the chair. I would help them get them back to bed, and that's as much as I would do. Right? But you have to be cognizantly aware of that. Call bell goes off in the hallway. Whose responsibility is it to answer the call bell? Everyone's. That includes the CEO of the company. If you have a hospital and the CEO is walking through that building and a call light goes off, that CEO should answer that call bell. Now, will that actually happen? I've only seen one hospital where that did. We actually had a CEO that walked the hallways and got people water and stuff like that. I was thoroughly amazed at that. Didn't help them get much else, but he would get them water, or he would go get them ice chips, or would go get the nurse if it was something that the nurse had to do, which I thought that was kind of pretty cool. I don't know about you guys, but seeing a CEO walking the floor and getting people water or getting them their bedpans, that's pretty cool. Right, or emptying I remember him emptying urinals. But if a light goes off, if you're near the room, you don't have to do what the patient needs. Right? You go in and the patient's like, I really have to go pee-pee. And you're not the patient's primary caregiver. You don't have the patient on caseload, blah, blah, blah. That's when you go, okay, let me go ahead and get your nurse for you. I was just going by and saw your light go on. Let me go find her. I'll let her know for you. Right? Now, does that mean you turn the light off automatically? Because this is another big one I see a lot. You just walk in and hit the light, turn the light out. No, you only turn the light out if you can do what? If you can provide them the care they need. I know nursing gets upset about, well, why didn't you turn the light out? Well, because I can't provide them with that care they need. That's why I came to get you. And there are some hospitals where that light, it has a timer on it. From the time the patient presses that light button until the time somebody comes in and helps them, it's timed. Because they want to make sure that patients are actually getting care. I understand the idea. I don't like the principle and concept of it, but all right. So we got off track there a little bit. So we're going to pretend that I am a 65-year-old patient. Okay. I'm 65 years old, male, and I'm just generally declined in health. So my body is just kind of worn down on me. I've got a pretty bad balance problem. So after I've kind of got my contraindications, after I've, kind of talked through giving you consent and stuff like that, let's say we're at the outpatient setting right now. One of the first questions you should ask your patient after you've done that is, have you fallen recently? Have you fallen within the last week? Have you fallen within the last 24 hours? Because the biggest predictor of somebody falling is a previous fall. If it's within the last year, they are likely to fall within the same year. So it's a huge, huge, huge indicator of falling. Make sure you ask them, have you fallen recently? Well, yeah, I fell 2 days ago. That should go in your subjective. Patient states, I fell 2 days ago, in quotes, right? So as you're explaining to the patient what to expect, what should you be doing to get your area set up for treatment? What should you be doing is kind of set your area up for success with balance treatments. Clear it. Yeah, get everything out of the way. This includes family members. Even if it's in an outpatient setting, hey, I just need some space here. Can you go on the other side of the room? Right? Get everything out of the way. Then with your patient, there are 2 things the patient should have on that are probably the most important 2 things for this treatment. What are the 2 things? Gait belt. Okay. Here's my gait belt. We're going to put my gait belt on me. Yep, it's going to stuck on my chair. That wouldn't be good. I'm going to be stuck to my chair. Not going to be doing any balance with me then. All right. So what if you put the gait belt on me backwards? Oh, no, I put the gait belt on me backwards. If you put the gait belt on me backwards, it's life, just flip it, right? With regular gait belts, right? Remember, feed the alligator. Can't tell you how many of you guys I've seen struggle with gait belts. All right, how snug should the gait belt be? I've got my gait belt on me. We'll move it up here so you can see it a little better. Yeah. I usually joke with my patients when I'm snugging it up. I say, can you breathe? They're like, yeah. I'm like, well, that's not snug enough. I joke with them about that. The reason for that is because I've had this before when we used to do transfers. Somebody will put this on, and then all of a sudden it's up in my armpits when they're transferring me. I hate that. Make sure it's good and snug. Get it below that rib flare. Let's say that I have abdominal surgery. I had a hernia surgery, or they went in and they fixed a bowel blockage. What do we do with the gait belt? If we can lower it, great. If not, then it's got to go up under the armpits. And I had this case once before. I have a pregnant mom that they had to do heart surgery on. Now what do you do? So she's got a chest wound. If you get room below the belly, great, do it. The other thing you can do is you can sling it low and across her hips. At least it gives you something. Honestly, what I did was I just transferred her out with a lift. I thought about it. It just wasn't safe for me to transfer her any other way. Right? It was just better for me to get her set up in a lift. lift her out to the chair and work with her that way than it was for me to worry about where to put the gait belt. So I got my gait belt on, and I saw somebody else reported. I think it was Kaylee that said it, right? Grippies, right? Look, Mr. McKeever keeps a pair of grippies at his house, right? So we're going to put the grippies on the patient. What is special about these grippies here? Why are they yellow? What does yellow indicate in the hospital? Yes, yellow indicates I'm a fall risk. And yellow socks usually have grippies on both the top and the bottom. See, my grippies have grippies all over. Blue usually is like medium, honestly. I think it's white, blue, brown, or small, medium, large, or at least most socks. Yellow is, they don't really indicate anything other than the size of the sock at that point. I've got a pair that are purple that I like, just because they're purple, and purple's my favorite color. But usually the only thing you really have to worry about is if they're a fall risk. If they are a fall risk, you have to make sure that you have the yellow socks. So please make sure that you're checking that. If they're a fall risk, you have to coordinate. Now, if your hospital has orange socks for fall risks, use orange socks. I'm just saying in general. All right, so I got my grippies on. I got my gait belt on. I'm feeling pretty safe. When should you put those on the patient? Should you put them on while they're laying down, when they're sitting up? In the inpatient world, I put them on before I even move them in the bed. Yeah, right? So if you're at the outpatient world, you may not have to put, the stuff on right there because they may have walked in or they may have came in with a family member, right? If you don't have grippies, what should the patient be wearing? Shoes. Yes. Now, that would have been a thing here with this comp. Had we done the practical exam, the number one reason why people failed their practical exam in this semester was not putting shoes or grippies on a patient, because that is considered a significant safety violation, right? So grippies are on. I got my grippies. I love my grippies. My grippies protect my feet. I got my gait belt. I feel really safe, right? Equally getting the patient prepared is getting yourself prepared. Because now you've got the patient set up. Now you have to get your own mind set up. So you have to be thinking to yourself that I'm going to be working with this patient now. I have to get my own head around this, right? Because maybe you've got a patient that's 400 pounds. If you've got a patient that's 400 pounds, that may be a different treatment thought process than a patient that's 125. All right, so now we get me up. You roll me out of my side. I do a log roll. I'm now sitting at the edge of the bed. Now we're going to work on this. This patient, we have a couple of different theories when we talk about balance, right? And we've talked about this before. We have dynamic and we have static, right? And we can have dynamic surface and static surface, or we can have dynamic movement or static movement. When static movement is not really static movement, right? So we have to think about the surface the patient's sitting on and whether they are moving or not, right? So if I am sitting here and I'm on a hard surface, we're going to pretend that my chair doesn't have wheels on it right now. I'm in a good solid chair. And you have me just sitting here upright, and I'm balancing just sitting upright with my eyes open. How would you describe that in your notes? Static on static. Good, right? I am statically sitting, I'm not moving on a static surface. Now, let's say you have me reaching for things. Now I am dynamic balance on a static surface, or static surface with dynamic balance, however you want to label it. You just have to be specific about that, right? So a lot of times we get really confused here and kind of get mixed up on the difference between balance and coordination because they're heavily tied with each other. Okay. So balance is my ability to just kind of hold myself in space. What does coordination mean? If I am a very uncoordinated person, yeah, am I able to do some form of controlled movement? And that can be as simple as this, right? That's kind of working my coordination. It can be something as simple as writing while I'm sitting here, right? Working on coordination. And then we're going to work on advanced coordination, right? That's when we start reaching cross body. So we're just going to start with static balance. And we're going to talk through kind of the progression here. So first level of static balance. I am going to be sitting at the edge of the bed on a static surface, statically, meaning not moving. Where should my hands be at the first level? On the bed. So I should be down like this, right? That's my first kind of, that is the most basic, yeah, or in the chair, right? I could be sitting back like this, right? So now I've got my hands here. I got my feet flat on the floor and I'm sitting nice and tall. That is kind of the first level of balance. The major difference between balance activities and therapeutic exercise, because we get really confused with these, because I guarantee I'm going to ask, how do we progress this? And somebody's going to say, add weight. Weight would be when we're thinking about therapeutic exercise, right? Balance is involving changing the surface, changing the time, changing whatever. So a lot of times when you're working with patients and you're doing Therax, right? Let me get my little drawer up here. When you're doing Therax, where's my cursor at? There it is. You'll see like 3 times 10 reps. When you do balance, a lot of times it's sets and time. So I sat here for 3 times 30 seconds, and I had a little break between each. It's not a hard rule, but that's one of the things I do to tend to separate out my balance activities from my therapeutic exercise. Is my balance activities I rate on a time, my therapeutic exercise I rate on sets and reps. Again, your clinic may be different, your rules may be different, but that's kind of the way I've always separated them out, because that helps me clearly identify when I bill what is therapeutic exercise and what is instead neuromuscular re-education, which is balance. All right, so now I'm better. You can progress me a little bit. What's my next progression from this position here? I'm staying in this position. I'm not going to move from in this position. What's my next progression? We're going to stay seated. We're going to stay seated. That's a little more advanced. Yes, my arms. My next progression is either hands. I can do the hands on leg. I can take a hand off, right? I always usually start by removing one hand and see how they are. And I usually remove the dominant hand, because that tells me a lot. If I remove the dominant hand and they're all over the place, I may not want to get to crossing my hands on their chest. So now I got one hand off. I can then go to kind of hands on legs. I can remove my hands there. This requires a good bit of core control, right? Because now I'm thinking, oh God, what if I'm worried about where my hands are. What if I go like this? Does that make that easier or harder? Balance. Makes it a little easier. What have I done at this point? Why do tightrope walkers walk like this? Yes, I've widened, whether I think about it or not, I've kind of widened my base of support. I've increased, instead of having a single line coming down where my gravity is coming through, I've created a triangle of support, which helps me in balance. Now, if I've got a shoulder issue, this is harder. So I don't do this a lot with patients. I'm like, okay, raise your arms out to the side. And they're like, they are, right? But now I move my hands. Let's say now I've got my hands. I'm good. I'm sitting like this. I can sit like this pretty good. Again, we're staying seated. What's my next progression? What could I do? Close the eyes. Good. I am not changing my surface yet. I'm not changing my activity. I'm keeping with the same activity. So now I can close, and I can start with one or I can do both. Right? I could say, close your left eye for me. Oh boy, what does that tell me if you start seeing me go and I close my left eye? What could that clue you into? Yeah, maybe I'm getting dizzy. Exactly, right? Maybe that left eye is what's interpreting my whole environment, right? For me, if you close my right eye, my balance gets worse because my left eye is not as focused, right? Just staring at the screen. Actually, I can read this screen because it's huge, thankfully. Introduction. Okay, I can read. But closing both eyes gets rough for people, right? Let me just show you, just, you know, from my TV eyes. If I just sit here, I'm at the edge of the chair. My bottom is literally just resting on the edge. I'm at the point where I'm kind of at that point of lightness. And I put my arms across my chest. And again, I'm not doing anything. This is not me faking it. This is not anything. I'm just going to close my eyes. What are you guys noticing? What did you guys see watching that for a few seconds? That was only a few seconds. Anyone? Bueller? Could you guys see? Yeah, okay, good. I started having a lack of balance. So it's important, you would have to indicate to what side I started going to. So what would you, let's say I was your patient, how would you clue me in? You're working with me. You've got your hand on the gait belt. You're kind of letting me go because you want to see how I am. What do you say to me? Like, Mr. McKeever. Yeah, sit up straight, right? What if when you say that, I say, I am sitting up straight? That tells me my proprioception's off, doesn't it? Right? That tells me my proprioception's way off. Now, I could actually feel myself, right? Could tug a little bit on the belt. Good. You may want to shift. If you notice that I start going to the left side, you may want to move to that left side just to be safe, right? Maybe the next time, so you go back upright and you change sides and you get on the left side. I like the idea of tapping on the shoulder. That's a fantastic idea, Javen. That's one of the ones I use big, right? I'm going to start going this way. I'm going, okay, come on, come my way, right? I will try to let them move themselves first back upright, but then if they can't, I'm going to move them back upright. And then I'm going to say, do you feel the difference? Oh, yeah, now I feel much more stable. Okay, good. Let's sit here for another 15 seconds. Oh, Mr. McKeever, you're going to that side again. Come on, sit upright, sit upright, sit up. Okay, good. Let's say that was what you worked on me with. How would you document that? And what you did was you talked me through it and you tapped my shoulder. What would you say? How would you document that in your notes? Now, you didn't physically pull me. You tapped on my right shoulder. Good. You gave me moderate. Good. Because that would be moderate cueing. You're exactly right. You gave me moderate verbal and tactile cueing by tapping on dominant side. Because well, not my dominant side, and I think about it, right? It's everyone else's dominant side, but my dominant side's over here. You tapped on my right side, right? That's kind of the way you're going, and that would be a moderate cueing. Right now, if you just were like, how do you feel? Oh, yeah, I feel myself going. Okay, I'm going to sit back up. That would be more of a minimal cueing. But if you're like, okay, Mr. McKeever, you're going, come on, sit back up, sit back up, sit back up, sit back up. Now you're doing a lot more moderate cueing. Literally maximal cueings where you're like, shut up, you idiot. Don't actually do that. Don't call patients idiots. Right? Okay, so now I'm okay with eyes closed. I'm not the best, but you definitely don't want to put me with eyes closed. Because eyes closed, I go all over the place. I'm sitting here like this, I'm pretty good. You close my eyes, I'm all over the place. Not changing surface, not changing activity, but you wanted to challenge my balance a little bit more. How could you challenge my balance a little bit more? Again, not closing the eyes, not changing the surface, not changing the activity. So I'm sitting like this. How else could you take away something to give me less balance? Yeah, you could have me lift one of my feet, right? Now I'm down to only one side. And look what happened on my trunk as soon as I lifted that foot. I'm over, oh, sit up, Mr. McKeever, right? You could raise the bed up to where I'm on my tippy toes, right? You could raise my chair. I could raise my chair up. I could cross one of my legs. Now this has changed my center of gravity, right? Now this is a little different balance posture, right? It's pretty rare that I will ever get to no feet on the floor. Because that's you get a patient that you can have them sit at the edge of the bed with no feet touching. They're pretty good balance-wise, wouldn't you think? I mean, if you get somebody that can sit there and have their feet off the floor, have their arms across their chest, they may not need physical therapy. I'm just saying for balance, right? All right, good. You guys are starting to think along the right path. Do you see how this process kind of plays out? Now, we're going to stick with the same activity. So I'm going to stay seated. I've kind of progressed through both hands on the mat, one hand on the mat, both hands off the mat, eyes open, eyes closed. You've moved a foot, you've moved both feet. Now you want to stay with the same activity. What is the next thing you change? So you want to stay with seated balance. What's the next thing you're going to change? Surface. Good, Dylan. Exactly. So you may grab something. Maybe you're like, oh, I'm going to get a pillow. Or I'm going to get a AirX pad. Or I'm going to get a Dynadisc, right? Which is going to be harder for the patient, a foam pad or a Dynadisc? The Dynadisc is typically going to be harder for the patient because the air shifts. Whereas with the foam pad, once they kind of get their butt in place, it kind of settles in. So a Dynadisc is basically, think of a flat ball. That's really what a Dynadisc, I'll bring up a picture of it then. Dynadisc is a round little disc that's inflated. And it provides them with a surface to kind of sit on that's very dynamic because as they move around, the air in that disc shifts and they have to compensate. So we're going to pretend that this is just an AirX pad, just a standard foam pad. So now I put that under my bottom. That changes my posture, right? And you want to make sure you get that Dynadisc or that pad or whatever you're using under their ischial tuberosity, under their ischial tuberosity specifically, because that's where a lot of the patient's weight is, right? So now I'm on this. Now you can begin the same progression, right? Arms down, one arm, both arms, eyes open, eyes closed, right? 1 foot up, 1 foot down, right? All of that we have stayed static. Now we can move into the same activity and seated here, and now go to dynamic. So dynamic means I'm going to start incorporating what? Movement, right? Now, before I go to movement here, would I want to take the foam pad out from under me at first? Yeah, right? So before we start incorporating movement, let's take this out from under you, Mr. McKeever, and let's try some stuff just on a static surface first. All right. So what kind of movements can you have me do that are kind of basic while I'm sitting here? Rocking back and forth. Great. Right? Forward and back, side to side. We start there, right? Next movements I usually do are head movements. Up, down, left, right. Because now I'm keeping my hands nice and steady. Right? Up, down, left, right. Maybe some head rolling. Because I guarantee you do head rolling with certain patients and all of a sudden they're going all over the place. A little bit side to side. I can even add head rolling while going side to side, because what I'm doing is I'm maximizing their base of support. Now I see people, Javen said reaching, right? So now we can move to reaching. Great idea, Javen. The first reaching we are going to do is linear reaching. What does that mean? Ipsilateral linear reaching. Ipsilateral meaning what? Same side. Ipsilateral is same side. Contralateral is opposite. So same side reaching, meaning that you're going to be reaching forward on the same side. Does that make sense? Let me tilt this camera down some more. There we go. So I'm going to start here. You're going to have me moving just straight out. So what could you say? You're sitting in front of me. You got your hand on my gate belt to keep me safe because, you know, you're really worried about me falling. What could you have me reach for? High fives? Great. Yep. But what if you really have to keep both hands on my gate belt? Just because I'm really worried about my balance. Cones, okay. I just usually have them touch my shoulders. Yeah. Right, so I'm sitting there, I got both hands on their gate belt, and I'm like, okay, touch my right shoulder. Whoops, that's my left shoulder. Touch my left shoulder. Yes, I'm from Pennsylvania. Touch my right shoulder, left shoulder, right shoulder. And I'm not tapping while I'm doing it. I'm giving them verbal cues. Now, I'm going to start with just say left, 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 right, 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 right. So I did a set of 5 on both sides. Then I can start having them get a little bit of cognitive work. How can I start doing cognitive work while doing this? While I'm doing it, instead of telling them to touch my left, I'm going to say, yeah, say what you're doing. Which shoulder are you touching? Left. Okay, right shoulder, left shoulder, left shoulder, right shoulder, right shoulder. Now you're starting to integrate a little bit of cognitive work with them, right? Or you just don't tell them what you're doing. You're okay, get ready. Right. Oh, okay. Left. Okay. Left. Okay. Right. Okay. Right. Okay. None. Now they've had to think as they're going through it. So that's ipsilateral, same plane reaching. That's the easiest form of reaching. That's reaching within the base of support, right? Because I'm reaching here. I'm within my base of support. I'm within my buttocks. I can do contralateral within base of support reaching. Now I'm going to take my right hand and touch my therapist's left shoulder. Left hand touches right shoulder. right? With my kids, I have them bop me on my head. Okay, bop me on the head with my right hand. Bop me on the head with your left hand. Bop me on the head with your right hand. Right? Bop, bop, bop. Right? And I'm usually beep, beep, moo, beep, moo. And I just have fun while I'm doing it. Old people think it's hilarious too when I do stuff like that, but that's okay. So that's within my base of support, right? Both of those are within, whether it's ipsilateral or contralateral. I'm within my base of support. That is easy dynamic balance. Now, once I go outside of my base of support, that is more challenging. Does that make sense? Because what have I done when I reach outside my base of support? I've changed where my vertical gravity line is, right? Because if I'm here, my vertical gravity line is going right down through my nose and going down through that S2 balance point and hitting the ground, right? I'm out here. Now that vertical gravity line is coming more through the lateral aspect of my face and kind of falling onto that right leg. That has changed that vertical gravity line. So I can start with ipsilateral reaching outside of my base of support. Reaching out here. Can reach out here. Right? I don't ever really get back to where I'm reaching behind them, but I mean, you theoretically could do that as well. So reaching outside, reaching outside, reaching outside, reaching outside, reaching outside, reaching outside. That is ipsilateral. How do I do contralateral outside of base of support? What do you think? We'll take a break here in a few minutes. Yeah, so now I'm way crossing midline. Right? For my kids, I have these two little buttons that are frogs. That when they smack them at rivets. Right? Rivet, rivet, rivet. Right? They're starting to reach. I can reach for cones. I could have a ball. Let's say you're working in the clinic and you know that your patient is a very, very bad fall risk, and you recruit one of the athletic trainers to help you. So your clinic has an athletic trainer, and you're like, hey, can you come help me with Mr. McKeever real quick? He's got some balance issues, and I really want to challenge him outside. I want him to reach for cones. Should you hold the cones or should you hold the patient? The patient. Yeah, right? Have the other person hold the cones. It could be a family member. Recruit mom or dad. Recruit the kids, right? Have them hold the cones. Have them running around with the cones around you, having them reach for the cones, right? Your hands are on the patient, and you're providing safety for that patient. Okay. So now I'm your patient. We're going to take it one step further before we take break here. I'm your patient. I've got pretty good static seated balance, so we're moving to dynamic. And let's say that I like building model airplanes. That's one of the things I really enjoy doing. How could you integrate that into balance? Yeah, there's a good one. Eric says, have the patient reach for the planes and tell you about them, right? Yeah. I've done it where I've gone to like Hobby Lobby or one of the stores and I bought a little $3 packet of, or $3 model airplane kit. And I have them reaching for the parts, pull the parts back in and pull a part out and set it on the table. Put the tools all around. Exactly. Okay, I want you to reach for the paintbrush. Okay, you got the paintbrush. Good. Now you got to put the paintbrush over there in the can. Right? Now, is that a lot of money? No. But is it like, yeah, make a paper airplane? Yeah, good. You could have them making a paper airplane. It's not a ton of money to do that, right? And you can have them bring stuff from home. There's nothing that says they can't bring stuff from home, right? I like my kids. I guarantee one of the big things my kids like doing is playing Mario Kart. I don't know what it is about Mario Kart. And even adults, I say Mario Kart and everyone starts getting, we're gonna play Mario Kart. Right? So I can break out a switch. It does feel cathartic, right? I can break out a switch, set the switch in front of them, and have them holding the controller, right? And I guarantee we start going around some of those corners, all of a sudden they're doing dynamic balance on their own. Because think about it, if any of you ever played Mario Kart, do you sit upright the whole time? Right? No, I don't know. even playing, I was playing some Forza last night. And I was talking to somebody on FaceTime and they're like, oh my God, do you realize that you rock back and forth as you're going through corners? And I didn't realize it. It never occurred to me. But evidently when I'm going around corners, I'm leaning like I'm in the car. Right? I'm getting dynamic balance, but that's something simple I can do that gets buy-in. Right? Now, instead of just doing reaching for cones and reaching for balls or touching my shoulder, now I'm doing something they enjoy. Now they are more likely to continue doing therapy. They're more likely to come back for therapy. They are more likely to continue doing their home exercise program. Just by doing something silly as having them bring one of their model airplane kits in. Right? They're gonna, whatever the model airplane kit is, hold on here, let's see. I actually happen to have, look, I've got a model kit right here. Why are you not? Oh, because they haven't sealed, that's why. If you're doing a model kit, you're going to have to break all these little pieces off anyway. Right? So why not bring it in and use it for therapy? Right? Have them bring their model kit in. I can have one box set here and one box set here. And this box is my parts, and I can have them transfer the parts over to this box. And then as they get better at it, I move the boxes further apart. I move them further out. Gundam build, yes. It's a Gundam. Right? Any of that works. I mean, I happen to love building model cars, so I've got my little WRX kit here. Somewhere I've got a 370Z and a bunch of other cars that kits as well. I seem to collect them and never build them. But yeah, this gets buy-in. What if I'm a football player and I got my bell rung? And so you're seeing me for balance. And let's say I'm a running back. What could you give me to get my buy-in with balance? Get a football. Now, instead of touching me on the shoulder with his hands, have him touch me on the shoulder with the football. Have him catching balls outside of his base of support. Just doing those little things. Yeah, Pat, help him do one-on-ones in the hospital hallway. Exactly. Ready? Down and up. Drive that sled. Drive that sled. Stop sharing here because we're going to take a break. Let me get over here. Stop share. Pause recording. And we are back from break. So this is directly out of your book. So this is the rehab book. This is just the digital version of your rehab book here. Talking about functional balance and how you rate and grade a patient's functional balance. Right? So when you're documenting a patient's balance, the only way they can have normal balance is if the patient is able to maintain steady balance without handheld support on a static surface, and the patient can shift and accept maximal challenge within line of sight in all directions. They can do dynamic. So in order for me to have a normal balance, I would have to be able to sit here on this chair statically, right, without handheld support. So my hands up here, however you want to do it. and maintain a good static balance, and then also be able to reach outside of my base of support to do stuff. That would be a normal balance. It's pretty rare when we have a patient that has balance issues for them to be normal. Most patients will qualify as either good or fair. And good is the patient is able to maintain balance without handheld support with limited postural sway. So if I'm sitting here and I've got no handheld support, I'm able to rock back a little bit and forth, but I'm not going out here and go, whoa, okay, I got to correct myself, right? No handheld support. I'm able to accept moderate challenge, meaning you're able to perturbate me moderately, and I'm able to pick stuff up off the floor without having to have handheld support. Fair is where we start getting into handheld support. Now, if I'm able to sit here, but I have to have my hands on the chair, I have to have my hands on the desk or whatever it is, the best I can ever be is fair. I'm going to say this because I guarantee on your boards, you're going to get a question and it's going to say the patient has static balance within, like super duper, can sit there for 15 minutes with bilateral handheld support, is able to accept moderate challenge, blah, 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 or maximal challenge, and is able to reach outside of base of support with handheld support. Doesn't matter. As long as they have handheld support, the best they can be is fair. That's just the way the balance grades go. Poor, patient's able to hold handheld support, but needs some assistance to maintain it. So moderate or maximum assistance to maintain posture. And able to accept challenge, unable to accept challenge without loss of balance. If you tap me, I'm like, over I go. And absent, the patient can't do anything. So these are kind of the documentations you're going to have. I just wandered around my house and I was like, what do I have in my house that I can use to challenge my balance? Well, here's one of them. It takes a certain amount of functional balance to be able to sit here, grab my drink, and take a drink while I'm sitting here. That's a fair activity. Putting socks on could be a fair activity. I've got a stress ball. I've got a Frisbee, right? I've got a pillow. Any of these work. I can get a duster and have the patient dusting while they're doing balance. I can have a patient read a book while they're sitting without handheld support, right? Any of that is a valid use of challenging balance. And we often don't think about it. We focus so heavily on, are we using cones? Are we using, I don't know, medicine balls, right? And we don't think about the simple stuff we can use. Just the other day, hold on here, there it is. I was talking to a couple of you the other day when we were doing comps. And one of the things everyone's forgetting on Dr. Ovreskin's comp is warm up. Well, I talked to one of the hand therapists and they're like, well, are they seeing patients at home? And this is just using stuff that's available at the patient. And I'm like, yeah, they're doing basically Zoom comps with me. And they're like, well, why don't you have them do a towel bike? And I'm like, what's a towel bike? And so he takes out his towel and he goes, have them doing an arm bike with a towel. Just have them do 3 minutes forward and then 3 minutes backwards. I was just absolutely blown away by that. I never would have thought of doing something like that. But it's absolutely so simple, and it mimics an upper body ergometer, right? I can bring it in. I can make a real wide one. I can kind of offset it. I never would have thought of that. But I showed it to like 2 other therapists. I'm like, I can't believe I didn't think about this. And they're like, oh my God. When the arm bike's up to use, I can still have the patient warming up. Something as simple as that, using stuff that you have in your environment can be huge. That brings into a question here. Would we want to treat a balanced patient over Zoom? What do you think? Probably not. Yeah, that sounds like a recipe for disaster. Right? I saw somewhere where they're like, we're treating stroke patients via Zoom. I'm like, oh my God. Oh my God. Like that to me is just terrifying to me. You know, total knee replacement, I guess I could see, total hip, stuff like that. Some of my peds patients that are really kind of high level functioning peds, I'm okay with. But like, I wouldn't want to treat somebody that's an absent balance grade patient via Zoom. That's just asking for a fall. All right, so before we move on to working through that, let's talk about some different balance testings we can have, right? So your book has all these outcome measures on testing, and I know probably you've seen some of these while you're out in the clinic, maybe the SIT-SIB, the Berg, the Tenetti, functional reach test. Timed up and go is probably the most common, right? The timed up and go is probably the most common balance test that's out there. How many of you guys saw the timed up and go while you were out in the clinic? The tug. Yes, Canada, yeah, right? This is probably one of the more common tests, right? So how do we do the time? Because I want to go over this. How do we do the timed up and go? Well, the timed up and go, it says here, it's a multitask performance test. Examines functional ability during stand up, walk 3 meters, turn, walk back, and sit down. It has excellent test, retest, and inter-rater reliability. So that means it has excellent ability to be correlative between testing periods. It is very highly inter-rater reliability related, meaning that if I do it and Michelle does it, our results should be pretty comparable. And is very good at predictive and concurrent validity, meaning that it'll give us pretty good idea if the patient's going to fall. So what do we have to do? Well, I set the timed up and go up here, right? Because my chair right now is about 3 meters away from my fan over there. So what we've got to do is we've got to have a chair with arms, right? We have to have a target goal to walk to. And a lot of times you can set a cone out there. You can set a piece of tape out there. Doesn't matter what you're going to do, right? Just so that it's clear where the patient's going to. I'm going to use that fan as my goal, and I'm going to walk around it and come back. So your patient should get up from the chair, walk 3 meters, do a turnaround, and walk back to their chair and sit down. And then you are going to time them. And you're going to use it 3 times for an average score. So on average, about 11 to 20 seconds should be somebody that's kind of frail and elderly, right? If it is greater than 30 seconds to go that 3 meters and back and stand up and sit down, that means that patient is at a high risk for falls. So you guys have to be very specific while you're doing with the patient. So you're going to explain to them, what we are going to do is the timed up and go now. This is a test to test your balance and your overall functional walking. What we are going to do is you're going to get up from your chair, not now, when I tell you to. You're going to walk down and around that fan over there. You're going to turn around and come back and sit down again. I'm going to start a timer, and you're going to do it the whole time you're walking. I'm going to time you there and back. Let me show you what this looks like. And then you're going to sit down in a chair beside them, and you're going to show them how to do it. Once they see how it's done, do you understand? Now you are going to do it. If your patient is a fall risk, should you let them do it on their own? No, you've got to walk with them. Right? I don't know exactly, right? You have to be able to time and guard them at the same time. That's not that hard, right? Especially nowadays that we can talk to people on our phones and our watches, right? So time it and guard them at the same time. If they have an assistive device, they need to use their assistive device. So if they're using crutches, if they're using a walker, if they're using or reciprocal gait orthosis, I don't know. If they're using any of those, they've got to use their assistive device. You can test them without it to just get a baseline of where they are without the assistive device, but that is going to require a lot more assistance on your part. So you're going to have me sit here and go, okay, Mr. McKeever, over there is your goal. I want you to walk around that and come back. I'm going to start the timer. Ready, set, and go. I'm going to stand up. I'm going to walk around my spot here. I'm going to come back. I'm going to reach back for my chair, and I'm going to sit down. And you are going to time me for that. That is why it's called the timed up and go. Now, as PTAs, are we going to then put in our assessment, patient, perform timed up and go today, and due to their MS, they've had poor performance on their timed up and go? No, we're not going to diagnose anything. We are literally just going to put timed up and go, trial 1, trial 2, trial 3, average of 3 trials, and document how they did. We can indicate in our assessment if they are a high risk for falls, because we have verifiable data showing if they took them more than 30 seconds to do it, they are at a high risk for falls. But we're not going to diagnose why they're at a high risk for falls. That's PT. We just have to diagnose or document what we're doing. That's probably one of the most common balance tests you're going to encounter is that tug. Functional reach test is a single task performance test, examines the limits of stability during standing forward reach. So you're going to actually have a patient reach out in front of them, and there's going to be a tape measure or a ruler or something beside them determining how far they can reach. That's probably the second most common balance test I've seen. And then you've got the Berg test. The Berg test runs through a bunch of tests, and I think I've got the Berg here in the, where's the Berg? Maybe the Berg isn't in here. The Berg has a bunch of little mini tests you're gonna do with them, right? So if you look up here on this for your book, multitask performance, 14 items, examines static and dynamic balance using 6 static and 8 dynamic tasks. And then you're gonna score them, right? If the patient scores below a 45 on the Berg, they are considered a severe fall risk, right? The max score is 56, 45 or under, they are a score. So if you remember that one patient we looked at the other day had a Berg score of 23, right? Remember the TBI, that patient had a Berg score of 23. If they have a Berg score of 23, that means they are going to fall. Just no other way about it. I think the worst I've seen ever is 16. And if you're getting a 16 out of 56, we've got some serious issues, right? So just understand with the Berg balance score, much like with the level of cognitive functioning score, much like the Glasgow Coma Scale, the lower the score, the worse your patient is. And if you look, the high score is 56, 45 or below is a high fall risk. You don't have much of a range there. You have 11 points before you're considered a high fall risk. So that's kind of important to understand. Now, what if your clinic uses the Tenetti or uses the balance evaluation testing system, the BEST, or the BEST is another one. We're going to go through the BEST when we go on campus. Well, if they use those, do them, right? If you don't understand how to do a test, make sure you ask. Don't pretend like you know how to do them. Make sure you're doing them properly. All right, so I'm going to go back to the comp sheet here. Where did that comp sheet go? Let's stop sharing. Back to my comp sheet. There it is. All right, so we've done a bunch of seated activities. Let's move to some standing activities. So one of the very first standing activities you can work with a patient on for balance is just simply sit to stand. Why is that one of the most simple balance activities you can work with your patient? Well, because in order to do anything in standing, you have to first teach them how to stand. Because most patients don't do it right. I mean, I've seen patients where they'll throw themselves way back and stand up like that. You know, I've seen patients that they're like all over the place. So I'm going to stand up right? You want to make sure you instruct them on proper sit to stand techniques. So we are going to go over sit to stand again. And the reason I keep beating this into you is because the boards love questions on sit to stand. All right, so I am sitting back in my wheelchair right now. Sitting here nice and comfortably, and you're going to teach me how to sit to stand. You've got the gait belt on me. You got grippies on my feet. We're ready to go. What's the first thing you're going to have me do? Okay, scoot to the edge of the chair. What if I can't scoot? I have difficulty moving my bottom. Help them, right? When you help them, you're not going to just grab them and drag them forward, right? Have them put their hands on the chair, scooch one bottom forward, one bottom forward, one bottom forward, one bottom forward. All right, I'm out at the edge of the chair now. Kelly's helped me get out to the edge of the chair. What is my next step for sit to stand? Okay, hands on the armrest. I'm going to keep my hands on my legs because my shoulders are killing me today. I did arm day yesterday. So we're going to pretend my arms are on the hands are on the armrest. Nose over toes. Good, right? And we may just practice that a few times. Okay, nose over toes. Nose over toes. Nose over toes. All right, you got that? I got that. I got that, Kelly. You really got me going here. Really good. All right, so now when I reach nose over toes, what's that point out here called? Where my bottom kind of is really kind of lifting up off the mat or the chair. Point of no return, pretty much, yeah. It's called the point of lightness. Lightness, Lighthness. The point of lightness is where kind of my ischial tuberosities almost start lifting up on their own. So out to the edge of the chair, nose over toes, point of lightness. And what's the next step? As Ludacris would say it, stand up. Right? So I'm going to get out here. I'm at that point of lightness. I'm going to do combined hip extension, knee extension in a closed chained activity and stand up. So now you got me standing up. I'm going to tilt the camera again. That's a little too far. Probably there. That'll be good. All right. So now you got me standing up. Then you can work on sitting down. Right? Again, sitting down, opposite. I'm going to reach back for the chair. I've got my hands on the chair. I'm going to lean forward slightly and push my bottom back into that chair as far as it'll go. I don't want to sit out here on the edge. If I sit out here on the edge, I'm likely to go down. I want to plant my bottom far back in the chair. All right. So now, we're going to work some standing balance stuff. Actually, let's see. Move my chair out of the way here. The chair's all beat up. Need to order a new one. All right, so I'm way out here. We're going to do standing balance stuff. How can you give me something to have bilateral hand support when I'm in standing? What could you do to give me bilateral hand support while I'm in standing? What kind of assistive device? No pole, okay. Parallel bars to start with, right? If I don't have the parallel bars, what type of assistive device should I be using? Yes, a standard walker. I mean, you could give them a pole. Dun, 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 I don't know. All right, now, I don't have parallel bars. I forgot to bring a standard walker. Uh-oh, I'm in trouble. Chair works, cane, or you become the assistive device. So you put your hands on their gait belt. Your arms now become their parallel bars. That means you have to have functional bicep isometric strength so that you can walk with them. I've done it a lot, especially when I'm working with a patient where maybe they are, I get to the room and they're like, I have to get out to the potty right now. Crap, I didn't bring an assistive device with me. So I thought we were just going to stand up. Well, I become that assistive device. You have to have functional bicep strength in order to maintain that so you can become their effective walker. So that means you got to have some guns, is all I'm saying. But let's now progress exactly like we progress in seated. Right? Can everyone still hear me? Am I talking loud enough? I know I'm a little ways away from the mic. Okay, good. The good news is the mic adjusts for me as I move farther away, which that's why I love my mic. All right, so first of all, I have bilateral hand support. I'm on a static surface. I've got two hand support. What's the first thing I'm going to take away? I'm going to take away one of my hands. Right, so now I've got a single hand support. Then I can take away both my hands. Now, I typically don't have somebody stand with their arms across their chest because that can get a little wobbly, right? But I can have them put their hands on their hips. Now we're balancing without hand support, right? Now, what can I do to challenge their balance? I've got hands off. They're standing here pretty good. The next thing I can have them do is what? Have them walk. Let's just stick with standing for now. Okay, I could change just the base of support. Good. Let's keep with wide base of support to start. So I'm wide base of support. What can I do to my eyes? I can close one of them. I can close both of them. Now that changes my balance. Once I've kind of got that, now I can start changing my base of support. I can start by, and I'm going to turn this down some here a little bit. Right? So you can see my feet. I can start by first just narrowing my base of support until I'm into a kind of a sharpened stance here where my feet are nice and close together. Once I got my feet close together, I can then start moving into a tandem where one foot is slightly in front of the other. Tandem is eventually going to get me. Yep, we can start. We're going to talk about perturbations in a second, Adrian. Right, the 4-stage balance test, exactly, Kelly, right? So now I can start moving in tandem. If I'm standing in tandem, what does this get me ready to do eventually? Walk. Because think about it, when I'm walking, I'm in tandem, right? So that's why tandem is kind of that next stage. So I can go tandem. Or this is also known as a Romberg stance, right? I can then go to sharpened Romberg. Well, maybe I can go sharpened Romberg where my toes, okay, I can get my balance here. I promise. Maybe not. It's my left leg. There we go. Now I got my balance, right? So now I've got there. What's the next stage to take away some of my base of support? I can have the patient do what type of stance? Stand on one foot. I can do single leg stance, right? Now, there's this funny test, I'll tell you about it, it's in your book, called the Stork Test. The Stork Test is having the patient put their hands on their hips, put their one foot on the inside of their other knee with the leg externally rotated, and come up onto the ball of your foot. A functional, normal, healthy adult should be able to hold that posture for 30 seconds. I don't know who came up with that test, but there's no way I can stand, right? It's a fun bar game, exactly. I can't even do it for 5 seconds. Right? Dr. Stork came up with it, but evidently that is a normal functional test. Stand on one foot with the foot externally rotated. All right. So then Adrian said perturbations. can do perturbations when I'm starting to get right before. So when do we do perturbations? I start perturbations right before I start doing dynamic activities. So perturbations are where I start tapping them all around, right? So before I start them doing movement activities, I'll start doing perturbations. So now I'll test them. Maybe they're standing up and I start kind of tapping them all around, right? Again, like we said before, you cannot get them mobile until they are stabile. So don't perturbate them if they can't hold their balance by themselves, because that's just mean, right? If they can't hold their balance statically without any challenge to it, pushing them around is just mean. That makes things a lot harder for them. So now you've got me standing up and you're checking my balance and you're watching for strategies. So I'm standing here and you're watching to see my strategies, right? To see if I am able to do it. What was the first balance strategy I'm going to use to maintain my balance? Do you remember? What's the first strategy I use to maintain my balance? Ankle strategy. Good, right? So you're going to see me kind of shifting around on my ankles. The next strategy is what? Not arms. Arms usually don't come until the end. That's when they start falling. Knee, right? What am I going to do to my knees? Bend, right? The knee strategy are also known as suspension, right? I kind of drop my base of support. What's my next strategy? I'm going up my leg before the step. The hip strategy, right? I start shifting my hips and bringing my hips back under me. And then my final strategy is that step. So that's what you're watching for. Those are compensations. So when you're watching me, you're watching my ankles, my knees, my hips, and if I'm taking steps. So that means you probably want the patient to be wearing what? Well, hopefully they're wearing shirts too, but shorts, right? You want to be able to see their knees, right? Because you want to be able to see when they get to that drop strategy, or see their ankle and see if they're kind of rolling all around. If they have, pants on, you may not see all that. Now you may, right? And especially if you start becoming a seasoned clinician, you probably are better at noticing that. But it's really easy if they've got shorts on to do it. Now, let's say I'm wearing those skinny jeans, right? Can that affect my balance? Yeah, right? It may actually give me more balance because maybe those are so tight that they're almost providing a support to my hips, right? So now I'm actually having a little bit, or maybe I have a little less balance because I don't have as much movement in my knees or my hips. This is why it's really important for your patients to dress appropriately for therapy. If they don't dress appropriately, it can really affect your therapy session. So you need to set that kind of standard. When you come into therapy, I need you to be wearing blah, 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 right? Just like we expect you guys to bring appropriate lab clothes, you should expect your patients to dress appropriately for therapy. And it's nothing wrong with it to tell the patient, hey, I need you to wear different clothes. If I'm working with, somebody on balance and they come in high heels, that may not be the best option. And they're like, well, I've got balance problems and I'm really get balance problems and I'm on high heels. Stop wearing high heels for a while. Like I blows my mind. I've had women come in those stupid skinny pencil dresses, right? Cowboy boots, exactly, right? You gotta tell them, okay, I need you to bring appropriate footwear. I need you to bring appropriate clothing. And then of course you can have the patients that are like, well, I'm going to bring booty shorts. Okay, whatever. If that's your thing, whatever. As long as I can see your hips and your knees, that's all I care about. right? That helps you kind of look at their balance. So remember, even when we're doing balance and we've got a patient that is a challenged balance patient, we still need to do the show, tell, do, right? Or do your STDs. So you may have to tell them what you're doing. You may have to show them what you're doing. You have to walk them through it. Be careful if you can't do the activities you're asking them to do, because they're expecting you to be able to show them how to do a tandem stance. They're expecting you to be able to show them how to stand on one foot. So if you're going to show it, make sure you show it on the side that you can do it on. I'm just saying, if you have balance challenge on your left side, do it on the right. Just kind of think about that before you treat your patient. All right, so surfaces to stand on. We've got static surfaces where we've got the floor. What kind of stuff can we challenge them? So we could add the RX pad. I got to bring up the Dynadisc for Adrian yet. Right, we've got the wobble board. There we go. There's a great one. Just standing on a slant board where they're slanted at a 45-degree angle can be a challenge. One foot on a stair and the other foot on the floor is a challenge for balance. And then one of the things people often forget about doing with patients that have balance is walking on gravel and grass. Shuttleboard works well too, yeah, right? But take them outside and see how their balance is in the real world. Go outside and have them walk in the parking lot a little bit, and then find an area of either real or fake grass and have them walk in that a little bit. Because that is what they're going to encounter in the real world, and we want to know how they do with it. You know, just walking in the clinic and the patient's like, yeah, I fell yesterday when I was walking in my yard. Well, why do they fall when they're walking in the yard? Because they haven't encountered that in the clinic. So getting them out and doing regular tight gait, even if it's just, you know, you don't have grass, you have dirt out back of the clinic. Great, take them out back and walk them in the dirt. Right? You know, we had when I was at, you know, I was in New York, Pennsylvania, we had somebody that worked at York College, and it was one of the coaches, and he'd gotten his bell rung, and he was walking fine until he got on AstroTurf, and AstroTurf was the problem. It was something about the texture of AstroTurf that threw his balance completely for a loop. So guess what? We had to treat him on AstroTurf. We had to get some AstroTurf and kind of work him walking on it. He brought some in from the groundskeeper, and we worked on standing on AstroTurf and working on AstroTurf because that was what he was going to be doing on a daily basis. Sometimes you just have to think of the outside of the box way, right? If your patient's got super high, what I call the sink in the floor carpet, you may have to work on that. You may have to do a home visit and see what their carpets are like. So be kind of thinking about that. If they've got a dog or a cat, well, you might have to think about planning on practicing walking and giving them cueing. Okay, your dog's walking in front of you now. What do you do? Oh, I got to stop for a second. Let them walk in front of me. Great, go ahead, right? I've walked where I'm working with a patient on balance where I'm pretending like my foot is their dog, and I keep kind of tapping the outsides of their legs and stuff while they're walking like a dog would. Because dogs and cats are trying to kill us all. They just are. So now let's say I've gotten the patient pretty good on static balance. I've got them pretty good on dynamic balance. I've got them on good static surface. I've got them on dynamic surface. And now I want to start incorporating coordination activities with the patient. Right? Gee, I wonder what I could do that would incorporate coordination activities with the patient. What kind of coordination am I using right now? Throwing, right? I'm using hand-eye coordination, aren't I? Even though I'm kind of looking at you guys, I'm still in the, there we go. I lost sight of it, so I lost control, right? That's coordination. Now I'm starting to get a little challenging. Now you have me up and standing, have me doing this a little bit. Now have me stand on one foot. Am I still able to do it? Have me raise my hands higher and do it. Have one hand high and one hand low. Oh, I lost it. And then you reset. Okay, get yourself set back up. Let's do that again. How could we check hand-foot coordination? How could we have them check hand-foot? Okay, bird dogs, great. We could have them kick a ball. Now, bird dogs are valid. Yeah, that's absolutely right. Right, we could have. My favorite activity to have them do is the 4-point star, where I have the patient stand in front of me. Move my chair out of the way a little bit. And I put a piece of tape in the front of them on each side and one to the back. And I have them tap, 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 back to middle. Tap, 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 tap. Now I'm doing coordination. I can then add and go, okay, tap the left side, tap the right side, left side, right side, left side, right side, front, back, front, back, front, back, front, back. I can have them do grapevine or karaoke when they're walking. Crossover, 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 crossover. That's starting to work coordination. Right? I can have them in the martial arts. We're talking about, can have them, maybe I have martial arts. I have them doing kicks. I can have them doing punches. Right? There are all kinds of techniques you can use to work coordination. I have my switch here. Even just sitting here playing switch is working coordination. If I'm working balance, because I'm now integrating a different sense while I'm actually doing an activity. The Wii. Honestly, one of the best things that ever came out was that stupid Wii bowling. And I don't know how many of you ever had a Wii Sports. I don't know how many of you ever seen like the old folks' homes when they get the Wii, right? Like, man, they get pretty aggressive with Wii bowling and Wii tennis. Like they will fight each other over it. They'll cut each other. Right? So all of that works kind of in the same manner, right? There's that new one that I just saw, and I still want to get it because I want to try it with the Switch. I think it's called the Ring Fit or something like that for the Switch, because I want to see if it's similar to what we had for the Switch before, or for the Wii. So if it's something I can integrate, I'll integrate with my clinics, right? It can actually get pretty intense. I had one of the big ones we had when the original Xbox One came out. The one clinic I was at bought the Kinect and had the, oh my God, what was it called? It was like extreme rafting or something like that on the Xbox One, where you were rafting down there and you had to paddle and you had to reach up and do stuff like that when you're going over the rapids. And so that was fantastic. Right? So there are ways we can do this that help get your balance and make it fun. It doesn't have to be all just dry, sit at the edge of the chair, right? You can be as creative as you want. Now, do you have to be that creative? No, absolutely not. Because I've had students who are like, I don't want to do this, Mr. McKeever. I just want the basics on how to treat a patient. Great. We just went over all the basics on how to do balance. We really did. Everything I just showed you can be applied to any balance activity you want to do. Right? You start with double hand support. You take one of the hand supports away. You take the other hand support away. You start getting narrower base support. You close their eyes. All of that is just the standard kind of progression. I didn't want to talk to you. Oh, that watch seems to want to talk to me. But that's kind of the progression. No matter what you are doing with a patient, whether you're doing seated balance, standing balance, anything like that, that's the progression when you're working through a patient. And it's important to think, well, I've got a patient that's got really, really bad balance, then go back to the absolute basics. But understand, if you've got a patient with balance issues Adding cuff weights is not necessarily going to help with balance. That's not the way we do it. Let's say you're working on sit to stands. Adding a weight vest may not affect their balance at all. It actually may make it better, right? But changing the base of support they're on, changing their technique, changing the number of reps and sets you do can be change that balance. So that's why I'm kind of going through this going, you have to think in the idea of balance. I mentioned it briefly before. What do we build balance under? As far as the CPT codes. Yes, neuro-re-ed, neuromuscular re-education. So when you are billing this, it is important that you are very clear on what is, because if you build gait, therex, and neuro-re-ed, it is really important to indicate which is gait, which is balance, you know, which is neuro-re-ed and which is therex. And a lot of times when I'm doing my documentation, I am literally going to separate out those sections. I'm going to say, here's my gait section, gait blurb. Here's my neuro-re-ed blurb. Here's my therex section, therex blurb. Now, what if you have a flow sheet? That's where it gets a little more difficult. And everyone has their different way of doing this. I tended to always put the codes behind my exercises when I'm working on them. You don't have to do that. I did that when I was at the outpatient clinic. So I would put which ones were 97110. So I'd say, you know, long arc quads, 97110. And then I do single leg stance. And oh my God, I can't think of what neuro-re-ed is off the top of my head right now. I think it's 112. Don't quote me on that. My brain's not there right now, or 116. I can't remember which it is. It's probably neither of those at this point. But I'm going to indicate which I'm billing for which, because that way when somebody comes in and audits me, they can clearly see if I bill for neuro-re-ed that I have a separate section for neuro-re-ed. Now, let's say you did neuro-re-ed for a patient and you just billed them therex. Is that fraudulent billing? So you saw them for neuro-re-ed, but you billed therex. Not really. That's not fraudulent billing. Because you can argue that even all neuro-re-ed activities are therapeutic activities or therapeutic exercises. But let's say you only ever do therex with the patient. You have them doing long arc quads, you have them doing squats, and you instead bill those as neuro-re-education. Would that be fraudulent? Yeah, right? So what I'm saying is all neuro-re-ed activities are going to be a form of therex, but not all therex are neuro-re-ed. Does that make sense? Does everyone understand what I'm saying there? Okay, because it's important to understand that. Because pretty much everything we can do, even walking a patient, couldn't we technically classify gait as therex? Yeah, we could, right? We can get away with classifying pretty much everything as therex. That doesn't mean that all of therex is gait, right? Doesn't mean that all of therex is neuro-re-ed. Now, like we get down to wound care, we can't really classify wound care as therex, right? That's a little reaching. Putting a Band-Aid on somebody is not exactly the same as doing therex, right? But most of our activities, we can theoretically find a way to call them therex. I am working with a patient that has balance activities. And you're working with them, and let's say that I have a right total knee replacement. Where should you be standing on me? What side should you be standing on? So I'm a right total knee replacement. Yeah, you should be standing on that right side, the total knee replacement side. Because remember, when a patient goes down, it's very rarely they are going to go down to their strong side, right? That's why strong side linebackers are always the best. Usually the weak side is going to collapse. And usually that irritates somebody in this group, but I don't think anyone played weak side linebacker, so it doesn't work. But standing on their weak side is typically going to be the beneficial type effect, especially if you have a stroke patient. Again, stroke patient working on that weak side is going to make them integrate that weak side again. So you kind of have to think through that. Now, why might I stand on the other side? Pusher syndrome. Let's say I've got a patient that is a stroke and they have a heavy pusher syndrome. So my left side is my affected side, and I've got a heavy left push. Why might I stand on the right side of the patient? Because you'd think you'd want to stand on the side I'm pushing to, right? Yeah, to pull them up. Or to tell them, hey, come over to me, lean on me, right? Now you've given them a kind of a tactile and an auditory goal to go towards, right? So now I'm kind of pushing like this, and you're like, okay, come on, lean over into me, Mr. McKeever, lean over into me. Now I'm over here, and you can keep me from overcorrecting, right? What happens if I am a bilateral knee replacement and I have balance issues? Where do you stand? Behind them is probably the best option, or in front, depending on what you're doing. If I've got a walker, it's kind of hard to stand in front of them, right? But if I'm just standing in front of them, we're just doing sit to stands, standing in front is the ideal place, right? How close should you be with your patient when you're working balance? Yeah. I tell my balance patients when I'm working with them that we are going to dance. You know, you're inside their bubble. Exactly. That's a great way to put it, Erica. You're in on them. Most of the times I'm on, if I don't have an assistive device, I'm in on them where my hands are behind their back on the gait belt. My arms are all the way around their sides, and they're often got their hands up here on my shoulders, you know, the lateral part of my shoulders, and we're dancing. Or I've got their hands on a gait belt that I might have around my waist, right? I just don't want them grabbing my neck. I don't want them grabbing my butt. But here's the deal. In a pinch, if it's the difference between a patient grabbing my butt and having good balance or grabbing my neck and choking me, grab my butt, grab my hips, I don't care. Right? I'd rather have that than another broken neck. So if that's where little old Millie feels comfortable is putting her hands right on my hip like we actually are dancing, okay, I'm going for it. Let's dance, Millie. As long as she's not giving me any pinches or gooses, I'm okay. Right? I am literally, and you know, I didn't get to teach you guys PTA201 because I gave that to Dr. SoCal to teach you guys, but I am literally on top of my patient. Yeah, gooses, right? I think that's an East Coast thing. I'm literally all up in their business. I'm just saying, especially if it's my first time treating the patient. If they say, well, yesterday I worked with Jaira and he wasn't this close to me. I'm like, well, you know what? That was him. This is me. I just want to see how you do. And then as they get better, I back away. Unless I see there's something like contact guard. If they're a contact guard assist or a supervision, I might start a little bit further away. But I still don't trust the previous PTA or previous PT. I know they gave me a guideline on what to go on, but I want to be safe because patients change day to day. You may go in to see them and all of a sudden they had a really bad psychotic night and now they're on Haldol. And they are literally all over the place. Right? Yesterday they're supervision and today they're max assist. If you aren't cognizant and patient and paying attention to this, you'll end up with a patient falling on you. And the one thing we know is, do we want a patient to fall? All right, we don't want patients to fall. All right, now that I said we don't want patients to fall, let's talk about falling. Because if you have a patient that falls regularly, guess what one of the things you're going to teach them how to do is? How to fall and how to recover. Right? So, I'm your average ordinary patient, and I'm going to fall. How am I going to fall? Which direction? Forward, right? Unless I'm a kid. So if I'm going to fall, most of the time, I'm going to go through all those strategies. There's my ankle, there's my drop, there's my hip. I'm going to step, and I'm going to fall like that. The two areas I am going to injure most likely are my knees and a foosh, fall on outstretched hands, right? Both of those are bad. So if I fall and land on my knees like I did, what are some of the outcomes that can happen from landing on my knees? So I come down, I land, bam, hard on my knees like this. Okay, I can end up with tears in my knee, right? I could end up with a patellar tendon tear, ACL, PCL, MCL, LCL tear. But when you think about it, when I land on my knees, all that force is getting transmitted right up to my hips. And I can end up with a broken hip. Exactly, right? I can end up with a severe lumbar strain from this, right? Maybe my hips don't absorb it and it gets transferred up to my low back. So don't only think that just this is where I'm going to have problems. It's really common if you look at old people that fall, their knees are usually banged up to high heaven because they landed on their knees first or they landed on their hips, right? So how should a patient fall if they need to fall? Let's say I've got a walker. What's the first thing I should do if I know I'm going down? Like, I know, danger, danger, Will Robinson, I'm going down no matter what. What should I do with that walker? Or crutches, or cane. Yeah, throw it away. Right? I teach my patients, if you know you're going down, get rid of that device. Because that device is only going to complicate things. You're going to hit your head on it. You're going to bang your shoulder, your hip, something to that effect. Just shove it out of the way, right? If I have crutches, let them go out to the side. In the martial arts, we teach break falling. And I'm sure Eric has probably heard that term before. I don't know. Maybe some of you that have ever been in the martial arts will hear that term. But we teach break falling. And I teach a lot of my patients similar techniques to break falling. And what a break falling is learning how to relax your body as you're falling, because the number one reason we get injured is because we tighten up. Right? When we start falling, we tense up. And we know, yeah, just like car accidents, right? We know that when we tense up, more injuries happen, right? So if I'm falling, let's just say I'm falling from this height, right? Yeah, you can see me. A break fall, when I go down, I'm going to use the lateral aspect of my arm rather than my hands to fall on. So as I'm going down, I'm going to break the ground with my arm. Not actually, the ground's not breaking. But I'm transferring force through the whole aspect of the lateral aspect of my arm. Now, I'm on blood thinners. What's my arm going to look like? Yeah, it's going to be bruised all high heaven. But now instead of having 145 pounds of Millie coming down on her hip, I've transferred some of that force out my arm. Less likely to fracture my hip. Right? In the martial arts, we used to do that all the time. We'd get up on chairs and jump off the chair and break fall onto the floor. Right? You see wrestlers do it all the time. Right? Any of you that watch that wonderful man's soap opera, WWE, right? When you see them land on their back, right? If they're here, make sure I don't hit my head. You'll see them slap their arms out to their side. Right? That's what makes that wonderful sound when they hit the mat. Right? For any of you, the guys and gals that watch the soap opera, The noise you hear on the mat is them actually transferring force out their body. Right? That's why, you know, King Kong Bundy can climb up to the top of a steel cage match, jump into the mat, and not break every bone in his body. Because they're trained how to land. Now, they probably also destroy their body in the process, but it's neither here nor there. Once a patient is on the floor, that starts the problem. Because now, here's the deal. A majority of old people that fall don't have somebody around to help them. So what can you teach a patient to do in order to make sure that if they fall, they are able to get help? How can we, so let's say that we got little Millie that she lives alone. You know, and we know she's a fall risk. Life alert can be good, right? Always fall near a phone. That works out well. Right, but what can we tell her to do about a phone? Keep your phone in your pocket. Right? Or what I'll do is if they've got a smartphone, I usually get them one of those little tethers that they can keep it around their neck. Right? Smartwatch. This watch that I have here has a fall sensor in it. Right? So I think it's with the iPhone 5, or the iPhones, the iWatch 5s and 6s, I think are the ones that have it in it. That if I fall and I'm an older adult, and this can be really, it's iWatch 4 and above. Okay, thanks, Jara. If I fall and go down and you have, let's say you have a grandma or grandpa. And now is grandma or grandpa always going to remember to put their iWatch on? Probably not. Right? But have them put this on. If they go for a fall, the watch will detect that fall. And it'll actually give them the ability to call for help. That is huge, right? Because that could be the difference between life and death. If I fall down and I break my left hip, and I've got a really bad break, I've got sharp bones all around a lot of blood vessels, right? And so as I'm laying there trying to crawl around and get off the floor, I'm moving and grinding that bone all around tissue and blood vessels and stuff like that. And I can rupture a major blood vessel down there pretty easy. And like if you injure that femoral artery, you can bleed out, I think, in 3 minutes. I think the 3 minutes or something. It's really quick. Don't quote me on the 3 minutes at this point. I'm not questioning my answer on that. But you can bleed out really quick. So having the ability for the watch to detect, hey, you have a fall. Do you want me to call 911? Yes, Alexa is a great, great, great option nowadays, right? I don't want one of those smart thingies in my house. Well, listen, Mom, the reason I want this is in case you do fall. I said it on purpose. Ha ha. Hey, Eric, it's Alexa. Play music. Did it? That's great. Yeah, and Alexa doesn't have to be on the patient then. I mean, it doesn't matter what your smart device is, right? You could use the good old Hey Google, right? What are the Google ones? The Nest, I think they're called. You can use the Miss S that I'm not going to say because like everything around me will go off because I've got an iPhone, iWatch, and MacBook Pro all around me that are detecting that right now. This is the fun part of my class. I can just start using smart assistants and like, yeah, be like, hey, Google, play a video. Hey, Amazon, play hard rock. Hey, Alexa, play hard rock. This is the fun of my class. I love it. All right, so let's take a quick break and then we'll talk about fall recovery. So let me stop sharing here. We'll pause. All right, so I'm recording again. So now we're coming back from break. We're going to talk a little bit about fall recovery. So now we're talking about what happens when you have a balanced patient and they've fallen, period. They're down. We talked a little bit about getting them some safety devices, such as smart devices, life alert, anything to that effect to help them. Again, keeping a phone on them can be really important, or keeping a phone within reach. The problem nowadays is most people don't have a telephone at home anymore, right? I don't have a home line. The only thing I have is my mobile phone now. I don't even have a physical. How many of you guys actually have still a physical phone that is not a Cox voice over IP phone? Like that actually comes from Verizon, or I don't even know who is the local phone provider in this area. Does anyone have that? Like a plain old telephone service line, POTS line? No one? Yeah, right. So no one has that anymore. So that's the thing to also think about is, let's say you got Millie, and Millie's got her little grandson, Bobby, and Bobby, well, not little grandson, but Bobby gets Millie, internet at home, and he gets her set up on Cox internet for their phone. And so she's got a phone service, she's got her home line, and all of a sudden, boom, it's a lightning storm and the power goes out. And now Millie's in the dark and Millie can't see, and Millie falls. But Millie was lucky because Millie kept her phone, her little portable phone, in her pocket. And she pulls her little portable phone out of her pocket and tries to make a phone call. What happens? Nothing. It's dead. Because when you don't have power, you don't have a modem. If you don't have a modem, you don't have internet. If you don't have an internet, hold on a second. Hold on. All right, that's done. Sorry. Yeah, if you don't have internet, you don't have phone service, you don't have anything to get a hold of somebody. Now, cell phones, in the best of times, it's great, right? Pretty much always have service. Whoop, that was good. I dropped mine. Thank God it's got a case on it. But what happens if let's say we're in a Hurricane Katrina type situation, right? Now, I don't know if you guys know about that, but when like those hurricanes come through, these phones become pretty much useless. Why do they become pretty much useless? Because everyone's using them at the same time, right? Have you guys ever gone to a Golden Knights game or a football game and tried to use your cell phone for data? What's it like using your cell phone for data when you've got 50,000 other people using, the network completely congested, right? You're like, I've got 5G. So now I've got 1 megabit per second connection, right? So that's kind of the thought process here when you're doing that, is that you have to be cognizant of this stuff. Now, the good news is stuff like Life Alert and that works on a radio frequency, so it doesn't necessarily work on the cell phone. And as we progress in cell phone technology, this will actually get a little bit better, especially when we start going to UHF and VHF cell phones. But that's down the line. That's kind of something down the road that when we get, that's going to be super wideband phone services. I prefer VHF for Weird Al, but when we get there, we'll have a lot ultra high frequency, a lot of bandwidth for the phone, so it might get a little bit better about it, but then it'll also be giving us cancer, so that's beside the point as well. Yeah, I'm glad you appreciate the movie. That's fantastic. I'll have to send you guys a guy I know did a cover of one of Weird Al's songs, and it was fantastic. But anyway, so patient's down, patient's fallen, patient can't get immediate help. So I'm 75 years old. I fell. I'm down. Maybe let's just say I fell in my living room to make it easier. I'm down. I can't get help. My phone's not working. I don't have Life Alert. This is a situation you may have to teach your patients, right? What do you do? right? So I'm down in the middle of the floor here. Right, so I'm down here in the middle of the floor. I fell on my left hip. I'm pretty much bruised on the side. I don't think anything's broken, right? Can you guys hear me from down here as I'm talking really loud? I hope the mic picked it up. All right, so what are my options at this point? Okay, good. I'm going to have to go back to primitive activities, right? Because I'm probably not going to be able to stand up from down here. Right now, you or I fall. We're just going to kind of roll over on our bottom and stand up, check ourselves off. Oh, we got a broken hip, go to the hospital. If I'm 75 years old, I may not be able to roll over to my side because I'm now all bruised. I may be unconscious for a while, right? I may have lost consciousness for 2 hours. And now I've got all that bruising pooling in my leg, and now that leg is numb and doesn't move. And now it's just dead. So I've got to crawl. So you've got to teach your patients, okay, you need to get over into belly down, right? And you need to teach them the old school army crawling where they use their forearms, right? If I've got a broken elbow, it's going to hurt. You know what's going to hurt worse? Dying, right? So they have to understand that they may have, their safety may involve them getting out of this trouble they're in, right? So what should they go for? What would be a good goal to go towards? I know, I mean, a chair. There we go, Adrian, right? So they should assess their area and say, where is the nearest chair or couch? Because again, we're going to regress to primitive activities. Because think about it, how did we learn how to stand up when we were a little baby? We pulled ourselves up to furniture, right? You just regress to that activity. So, you know, you're looking around. I got a chair behind me over here. So I've got to kind of get myself shifted around until I can get a hold of this chair. Now, hopefully this chair is on wheels because this chair on wheels can make it very difficult. But we're going to pretend that my chair isn't on wheels. So there's my chair. What should be my first goal? To get up onto what position? Seated's kind of where I get to kneeling. Yeah. Or quadruped or whatever you want to call it. I want to get up to where I'm here. Right? In this position, even if this leg is completely dead and broken, I now have leverage. And the patient may say, well, you know, this happened. The patient will say, I got up to that position and the pain was so great, I passed out. Okay, but they're in a different position at that point and they're more vertical. That presents better opportunity to breathe, better opportunity for blood flow. Okay, so now I get here. Now I can pull myself up onto this chair if I need to. Right, there are methods that I can use, right? I can start by kind of pulling myself up. Now, once I'm in seated, now I can assess my environment. What do I have that I can get help with? What do I have around me that I can get help with? Maybe I do have a rolling chair. Now I can use that rolling chair to get around my room, can't I? Right? So getting up into that high kneeling and then into that quadruped can be a huge thing to help them from dying. Let's say I fall in the bathtub, because this is a real situation here very frequently. I fall in the bathtub. I pass out, bam, smack my head, knock myself out for a few minutes. I come to, the shower is still running. What should be my first goal if the shower is still running and I've fallen in the bathtub? Turn off the water. Yes. 2 reasons. Number 1, I don't want to drown. Right? Even that water splashing me in the face, I can drown in it. What's the other reason? What is water doing to my body? Well, shriveling. Okay, yeah, that's true. That too. It's the water, honest. Well, it could be warming or it could be cooling. If I have hot water, great. It's warming me up and that actually is a benefit. right? Or I may want to save that hot water. Normally at that point, if it's been running that long, the water is now cold. It's now robbing me of my body heat, right? So if it's robbing me of my body heat, I'm going to go into hypothermia because water transmits heat much better than air, right? So it's going to suck all that heat right off me. Even if I have water on me, it's going to be robbing me of heat, right? Did you ever get in the pool and it's really hot outside and you get in the pool and you go swimming around and then you stand up in the air and you're like, holy crap, it's cold, right? Because the water has kind of sucked all that heat out of your body. And that's why it feels good to be in the pool, because the pool kind of cools your core, right? All right, so now I've got the water shut off. I don't think I can get out of the tub. The edge of the tub is just too high. I don't think I can pull myself out and over it. I'm too injured. What's my next step? And these are the things you might want to talk to your patients about. I'm serious. You guys may be thinking this is a little bit kind of far-fetched out there, but this is true. What should be the patient's next goal be? I'm in the tub, I'm stuck, bang on the wall to alert someone. Great. Yep. Knock on the walls, bang on the walls, try to get some help, right? Hopefully you have a phone again nearby. Press your life alert. If you're stuck in the tub and you have no option, the next option is corpse preservation, right? That means they need to find stuff to cover themselves up with. So it could be a towel. It could be the floor mat, whatever it is. Right now, they may have to use the hot water to keep themselves warm every now and then. But remember, every time they warm themselves up with that water, as soon as the water cools off, they've robbed themselves of heat. Right? That's why if you do warm yourself up with the water, once the water gets cold, shut the water off and cover yourself back up with something to maintain that body heat. Right? You guys have all done this, right? You ever not tired at night and you go get a really, really super hot shower? You dry off and then you go jump in the bed and you pull the covers over you and you're like, that heat just kind of encases around you and all of a sudden you're asleep, right? Because you've got that extra generation of heat. But if you just stand out in the air, all that heat escapes. So if patient's stuck in the bathtub, the next thing you're gonna have to try to do is get out of that bathtub, right? And that could be painful. And we've had to do that in the hospital where we've had to train patients how to get out of bathtubs. Ideally, we want to do a home assessment before then and see if that's a problem, right? Maybe it's not time to get a bath in the bathtub anymore. It's time to use a stand-up shower from now on, right? That doesn't have that lip to get out of. Or maybe it's time to put a chair in there, right? So that they get in the situation, they pull themselves up to the chair. That all comes into balance training. It doesn't matter, again, with an older person, with a person with a vestibular issue, with a person with a stroke, with a person with a spinal cord injury. It's not if they fall. It is when they fall. It's the same thing. I used to ride motorcycles all the time. The big thing on the motorcycle is not if you go down, it's when you go down. Same thing here. It's not if you fall, it's when you fall. And you have to think, am I prepared in case I fall with a plan? Right? So that's working with your patients on having a plan to get up if they fall. Why are they coming to therapy then? Well, they might be coming to therapy to learn how to get up, but the primary goal of therapy is not to teach them how to get up. That's part of it. The primary goal is to make sure they don't fall in the first place, right? Let's think about this. We are going to magically change the US healthcare system right now. Magic. And we can make it that every person 65 or years or older gets 1 week worth of physical therapy every year to help prevent falls. Free of charge. No copays, no co-insurance. It's 1 week full of free physical therapy. It's 3 days in that full week, and they get fall prevention. Would that change the number of people dying from falls? Absolutely. Right? So would that be expensive? I mean, Relatively, yeah. But I'd be curious if we looked at the cost benefit. If we looked at how much we'd pay out to get every senior citizen 1 week of physical therapy, 3 visits, versus how much we pay out for falls and, you know, hip fractures. And I'd be willing to bet this would be cheaper over here. I mean, we just are the cheaper option. It's just the way it is. So talk to your patients when you're working with them. How many times have you fallen recent methods? You know, if you've fallen in a year, that means you're likely to fall again, right? MS patients, likely to fall. Parkinson's patients, likely to fall. Kids, almost guaranteed to fall because kids just do it, right? The only difference between kids and adults is when they fall, they just bounce right back up. For us, we fall and we lay there and help. I fallen and I can't get up. All right, let's look at a quick case study here real quick, and then we'll probably end up a little bit here early. So let me switch over to that case study. Where is, hold on here. I got to figure out which screen is the right one. That is outcomes, that is examination. So we're going to look at the examination by a PT of a patient with Parkinson's. I know this is actually a vestibular issue. So let me check what quality this is. Auto, good. Volume all the way up. And share screen, that is, this one is called examination. Okay. I'm not trying to minimize the Zoom recording. I'm trying to get to the screen, share screen. Share computer sound. All right, can everyone see the blurry picture? All right, so here we go.
The patient is an 81-year-old male referred to vestibular rehabilitation for dizziness and imbalance. Here the patient is tested in Condition 1 of the Modified Clinical Test for Sensory Integration and Balance. Minimal sway is observed. During Condition 2, an increase in lateral sway is observed. During Condition 3, with the patient's eyes open while standing on foam, minimal sway is observed. During Condition 4, increased sway is observed and the patient loses his balance in a posterior direction after 12 seconds. Using the dynamic gait index, the patient is first asked to walk straight down the hall at a comfortable speed. The patient manages to stay on the center line and step length and width are normal. Only a minor drift is observed. The patient is then asked to continue walking while instructed by the therapist to look right, left, and center. Next, he is asked to look up, down, and straight ahead when instructed. No additional gait deviations are observed in either task. When the patient is instructed to make a 180-degree turn and stop when directed, he takes slightly longer than 3 seconds. Here the patient inadvertently strikes the last object with his leg while navigating obstacles in his path. The patient has difficulty stepping over a 6-inch high obstacle and needs to pause to safely negotiate the step. He can ascend and descend the stairs step over step, but requires the use of the railing to maintain balance. As only minor deviations were observed with the patient's habitual gait using simple head turns, he is asked to perform more complex head motions. Here, the patient is observed drifting side to side as he turns his head. Now he is asked to move his head and look in the opposite direction. Again, a noticeable drift is observed when he turns his head. These two head motions are similar to those used when scanning the shelves in a grocery store. The patient is also asked to walk in tandem with his eyes closed. He demonstrates difficulty with this task, making step reactions and reaching for the railing to maintain his balance.
All right, so stop share. Yeah, no gate belt. That was the first thing I was going to say, right? Like literally my first comment I'm looking at is no gate belt. I was concerned with him being in that corner as well by himself, right? I don't think I would have, I mean, the corner is a good idea. That's actually a really good idea to give him something in case he needs support. Watching the video was pretty scary in general. And the good news is they did this. Yeah, this was an accident. They did this in a controlled environment on purpose, right? That's why they kind of did this to give us some food for thought. Now that was an eval. Maybe we'll just assume that PT didn't get the message they're supposed to put a gait belt on the patient, right? So you saw when he was standing there, anytime he closed his eyes, he started losing balance. What kind of does that clue you in about the patient? What's he using primarily for balance? His eyes. Yeah, right? That tells you his proprioceptive system and his vestibular system may not be 100%. And we're going to talk about what will cause that, I think, late next week. What the vestibular system, how that works and stuff like that, right? But you saw, oh boy, he started losing that visual system, and all of a sudden he was all over the place. Gait. What did you notice with his gait? What side did he list towards mainly? Yeah, he definitely listed to the left. So he's kind of leaning to that left, but you notice he kind of deviated to the right because of his trying to compensate for that list, right? So he would lean to one side and then he would go off to the other. Tells you his proprioception is off. His balance sense with that vestibular, spinal vestibular tract is off, right? He's not getting, or vestibular spinal, he's not getting a good feedback. So what would be your concerns for him going home? You know that he's probably going to do what? He's probably going to fall, right? Yeah, as soon as you lose part of your vision, right? All of our balance is based on our eyes, our vestibular system, a little bit of our hearing, and our proprioception. You knock one of those out, our balance is off whack until we can compensate with the other devices. Exactly. That was what I noticed, Kelly. Kelly brought up a good point. He was so cautious. That tells you he probably fell before, right? Especially when he was doing that tandem walking, you saw his hand was on, he was not letting go of that railing, right? That also told me he wasn't comfortable with the physical therapist. Yeah, and going over the box especially, right? And all of that. I like that they brought up how he was kind of doing motions like this, and that was where he lost it and was like operating in a grocery store. It is, right? And he's probably going to encounter that. So do you think he's going to the grocery store with balance like that? No. Right? So he may not be getting the best nutrition either now because he's not safe, and he knows he's not safe. Overall, looking at that with that patient, I'm going, man, that guy's got some serious problems, and I feel bad for him, right? So let's look at some interventions here we're going to work with this patient. So let me share screen. Interventions. All right, so first thing you'll notice, let's see if he's got a gait belt on for interventions. I'm going to say probably no.
The following treatment segments take place 4 weeks after initial examination. To facilitate adaptation in postural sway and sensory organization, the patient is asked to maintain balance with eyes closed and feet together. The minimal sway allows the brain to adapt to the stimulus and will also decrease dependence on vision to maintain balance. As a progression, the patient places one foot slightly ahead of the other. This narrows the patient's stance and results in an increase in lateral sway. He practices standing on foam with eyes closed. This forces reliance solely on vestibular information to maintain balance. The wider base of support allows him to maintain balance for the entire minute. Here he walks in tandem with eyes open. The goal of this narrowed gait is to improve lateral stability and reduce the tendency to drift from side to side when walking. To challenge the vestibular spinal reflex, the patient is asked to walk at a normal pace while turning the head and looking to the side. The therapist observes for potential gait deviations, such as a wider base of support, decreased step length, a change in gait speed, or inability to walk in a straight forward trajectory. Performance while looking to the opposite side is compared. Often, patients exhibit more gait deviations when turning their head toward the affected side. Owing to difficulty with the dynamic visual acuity test, the patient is asked to practice ×1 viewing exercises for both the horizontal and vertical vestibular ocular reflex. The patient is asked to oscillate the head side to side while maintaining focus on the target in front of him. He is instructed to slow down if the target moves or becomes distorted. A larger target is used because of his poor baseline acuity.
All right. So Kelly brought up a good point there. Kelly said that he's got a slight limp that does make him go left. Absolutely, right? But you heard also they said that when a patient's got a problem, especially with the vestibular system, they tend to drift towards that side. Yeah, sometimes not. That's one of those that it could be, it could not. We have to pay attention to that. It's a good idea to look at that, but it doesn't always mean, you know, we hope that if it quacks like a duck and it's got webbed feet and it walks like a duck, that it's a duck. But sometimes it's a goose. So we have to kind of keep an eye out for that. But you saw that when especially when he was turning his head, he started going the direction that he was turning his head, right? That's because his body's going with his vision. What they did there towards the end was called vestibular ocular reflex training, or VOR1. We'll talk about that when we get into vestibular training, but it's where you're going to give them a visual target in front of them. And with that visual target, they're going to focus on that visual target and turn their heads from side to side, and then up and down, and then diagonal. And the goal is to keep focus on the target. That if I start turning this way and it starts getting blurry, then I got to slow down and get it back in focus. And then I can speed up a little bit more. And then as it gets blurry, I got to slow back down. The goal is to reintegrate the vestibular system with the ocular, the visual system, right? Standing on that foam showed that the problem probably wasn't his proprioceptive system. When he stood on the foam, he knocked that out. He still had balance issues. That clued me in that it's probably more of a vestibular issue with this patient, right? So we were working on kind of reintegrating that system, getting his brain to fire properly. Now, if we can't get his brain to fire back to where it used to be, the only thing we can do at that point is compensate for his loss. And there are compensatory exercises we can do as well, which we'll talk about when we talk about vestibular. So let's now look at outcomes. This is looking at him a little bit after he's done some therapy. And let's see what happens here.
The following outcomes were filmed 9 weeks after initial examination. As part of the home program, the patient was instructed to practice standing on foam with eyes open. The goal of this activity is to improve his ability to negotiate uneven surfaces in the environment, such as sidewalks. He maintains half tandem on the foam and is now ambulating outdoors without a cane. The patient maintains balance on foam for 30 seconds with feet together and eyes closed, satisfying condition 4 of the modified clinical test for sensory integration and balance. This indicates he is now using vestibular information to maintain balance. This also suggests improved postural sway control and sensory organization. The patient is now able to turn to the right in under 3 seconds. When walking around obstacles, he continues to trip over the last obstacle, losing his balance. Ability to negotiate a 6-inch obstacle has improved, but he accomplishes this by swinging the leg around the step instead of over it. The patient can now ascend stairs without the railing, but has difficulty attempting to descend the stairs without upper extremity support. This may be related to a 2-line degradation in the patient's asymmetrical acuity since initial evaluation.
Of course. That's what it means, of course. Yeah, don't worry about that 2-line acuity. Why do you think he's having more difficulty going downstairs than upstairs? Don't even go into this 2-line acuity stuff. Why do you think he's having Okay, gravity. Good. Yes, that's exactly right, Jaira. He sees the height in front of him. His depth perception is now, he's got macular degeneration, right? His eyes are getting a little older. He's getting presbyopia. And he looks down and he sees down. And what is he probably thinking? Yeah, I'm going to fall. Exactly. He looks down the stairs and goes, oh my God. He probably, yeah, it's a long way. He probably, when he fell for the first time, probably fell on stairs. Right? And it's a learned behavior that you look down those stairs down, you go, right? I'm going to get a hold of both rails and I'm making sure I don't fall again. Right? And that become a learned behavior. But in reality, I'm not so concerned as a PTA or probably a PT either. If I see him using a railing to go up and down stairs, it almost makes me feel a little bit better because now I know he's taking safety initiatives. The only time I'm concerned with that is if he has stairs at home and doesn't have a railing, right? If he has stairs at home and has no railing, well, then I'm going to have to teach him to go up and down stairs without railing. You know, where I'm from back in Pennsylvania, and I haven't seen any homes like this out here, but I'm not even being facetious about this. The stairs in my original home that I grew up in were probably, maybe if I'm lucky, 3 feet wide. Maybe if I'm lucky, 3 feet wide, you know, about a yard wide. And I don't even think they were that wide. And they were probably easily 45 degrees up. It was more like a ladder than it was stairs. And a lot of old homes are that way, especially back on the East Coast, because they try to cram as much home as possible into such a small area so they could build row homes, right? That's where, like literally where I'm from in Pennsylvania, it's row home after row home after row home after row home after row home. And the stairs in those homes are horrible. They aren't, you know, these grandiose staircases with, there's no room to put a railing, right? I remember as a kid, I had to learn how to basically climb up those stairs because I couldn't walk up them. And most of the time the stairs were like 8-inch steps. And so maybe he has steps like that in his home. He's not going to be able to use a railing. So we may have to teach him how to go up and down stairs without it, right? I may teach him to sit on his butt to go downstairs if I'm really worried about him falling downstairs, right? I may teach him, you know, the old fashioned way we went down as a kid, right? Slide down, slide down, slide. You remember doing that as a kid? Right? Now we're not going to put him in a laundry basket and have him go downstairs that way. That would be just cruel, right? Or put a slide in. But there are techniques we can teach him. Did you notice though, when he was doing those the standing in the corner balance activities, his balance was markedly better. He definitely did not have as much postural sway in static standing, or even in the dynamic surface standing in static, right? But man, as soon as we started moving again, his balance wasn't the best, was it? Right? And negotiating objects, he cheated. So that would be on us, right? What would happen? Let's say that we're working with him. We'll call him Bob. And Bob and you and I are working together, and you're my student. And we see Bob doing circumduction to go over that step. What do? How do we handle it? What do you guys think? All right, Bob, stop. Good. Exactly. So Kenna's right. All right, stop, Bob. 1 second. Put a chair there, right? Have him sit in a chair. Bob, remember, this is the way I want you to go over this step, right? So he's sitting there in this chair, and you do it 3 or 4 times, just so you see him seeing you do it 3 or 4 times. All right, do you understand what I want you to do, Bob? Bob's like, okay, right? You get him up, and then you have him redo it. He swings his leg again. Stop. Let's do it again. Let's break it down into parts, Bob. Let's get to the step. Okay, you're at the step now. Let's use your right leg and step over the step, Bob. Okay, now you've stepped over the step. Let's bring your left leg over the step. And sometimes that you're going to have to break it down into those minutia details so that Bob understands how to do it. I wouldn't be happy if that was my outcome and he was cheating like that. Because who taught him how to do that? Yeah, the PTA. PT or the PTA. Well, if he's with the PTA, I'll blame it on the PT. But we allowed him to do that. If we allow him to get away with that, that will become learned behavior. Right? And let's say he comes to a curb where he can't swing his leg out like that. Yeah, it's going to be very hard to break that habit now. You know, maybe he's out walking on the Las Vegas Strip and he comes to an area where he doesn't have room to swing his leg out and circumduct because he's got 50 other people around him. He's going to get stuck, right? And he's going to need help. And he's going to have to look around him and say, hey, ma'am, sir, can you help me get over this, please? And that's going to be harder on him than it's going to be on the people around him. And honestly, in this town, there's a good chance he may never find anyone to help him, right? And he may be stuck there at the edge of the road because no one wants to help him. I'm hoping that there'd be at least one good Samaritan that would help him, right? It's Vegas, though, exactly, right? That's the thing. And they may be drunk, and I don't know if they're allowed to help when they're drunk. But that's kind of the thought process here. We taught him how to do that. And because we allowed that to happen, he's going to continue to do it. That's our fault. That happened here. I'm sorry to hear that, Renee. It's really common, right? I've gotten off I remember when I was riding motorcycle, I was down on Trop and Sandhill, I think it was. I pulled over and there was this little old lady that was crossing the street, and man, she had to be 100 years old. And she got the green light to cross, but man, she couldn't get across. Man, I had to pull over and just walk her across the street because she just couldn't do it on her own. But a lot of people won't do that. They'll just sit there and honk their horn at her. Get out of my way, Grandma. Right? I'm late for work. I'm late for a very important date. So this is all about teaching people to become functional balance in the real world. And that can be really difficult. Right? So you have to take this all into kind of effect. Some dude on a dark highway needs help. Sorry, not sorry. That's probably a safe, Eric, that's probably a safe bet, right? Especially if you're like down south of Las Vegas in the area of the desert. That's the beginning of The Hills Have Eyes. I'm just saying. Or like outside of, if you go out south of Kingman towards towards Phoenix, when you get out in that area, man, there's nothing out there, right? Now, if some dude out there needs help crossing the road, he can figure it out. I'm sorry. I'm not about to become human jerky. So, but, you know, these are the things, these are the things we have to think about, though, because if that learned behavior bugs me, because that means we taught him that, and we shouldn't be doing that type of stuff. I mean, the good news is we helped his static balance. That's fantastic. So when he's standing shaving, he's good. But when he has to move around his home, if he has to step over something, if he's in a trailer, he's out of luck. Because trailers don't have a lot of room to circumduct your leg. Right? So these are the thought processes you have to go through. Don't teach your patients bad habits. Right? You remember growing up, your mom always tried to get you out of the bad habits, right? Don't sit so close to the TV. Don't chew with your mouth open. Don't chew bubble gum and walk at the same time. No, that's not a bad habit. But when we reinforce bad habits, it can be a pain in the butt to break them. I am 100% guilty of this. When I'm playing video games, this is my posture, right? It is a bad habit. And I've been really struggling breaking that bad habit. I actually got, guilty as charged, right? I actually got a figure 8 brace so that when I'm playing video games, it's forcing my shoulders back, which has given me a lot better posture when I'm gaming, right? But when you develop a bad habit, it becomes very hard. When you develop a bad habit for balance, it's even harder to break because you start integrating that into your neurological system. Just this is just a physical bad habit, right? Sitting forward, playing, texting, whatever, right? This is a physical bad habit. Physical bad habits, hard to break, but physical. Neurological bad habits, hard to break, but neurological, and now you have to integrate the brain as well. Yep, there's all kinds of devices out there like that now. There's one that I just saw the other day that puts a little electrode on your neck that when it leans forward, it gives you a little zap. I thought that was actually pretty cool. Now it's not like a shock collar zap, but like a little E-stim zap that kind of reminds you to sit up straight. I probably need the dog collar zap. I'm going to be honest. That probably would be more beneficial for me. Like, okay, I'm up. Right? Or just trigger, like put them back here on my erector spinae so that every time I slouch forward, it just gives me a Russian shock to my erector spinae. One of the two. Now we talked about balance in the general sense, right? We also have to think about what if a patient has muscular issues? Well, then we've got to not only integrate balance training, but we also have to integrate strengthening, right? So maybe they've got a weak tibialis anterior, and that's why he's clearing his foot the way he's clearing it. Okay, that means we need to work on that tibialis anterior, right? That means we have another goal we have to work towards. And once we integrate both goals, the patient will get better, right? But also the patient's going to have to be doing their HEP, right? We can't fix a balance issue without a patient doing their HEP. They have got to work with us on that, right? And that's where we have to get their buy-in. We have to get them doing stuff they're going to enjoy. Any questions on balance? Did that kind of give you guys a kind of overview, a really good balanced effort on it? I have issues, I know. All right, so I did put up drop boxes. Yikes, exactly. I did put up drop boxes for both the balance comp and the progressive gait comp. Again, I don't need a, what do you call it? A peer comp sign off. I just want you to sign the top, date the top, and post it. So that way I can fill out the rest of it so you can get credit for it. I made it due at the end of the week. If you get it done right now, it's done. But I made it due by Saturday, so just try to get it to me so that I can get it posted because I still have to keep copies of it up. And then Wednesday, we'll start talking about neurological gait because we talked briefly about, you talked with Dr. Sokel about gait cycling, right? 2-point, 3-point, 4-point gait, that type thing. We need now to talk about how to do that gait cycling with somebody that's got a neurological condition. And that's what Wednesday is going to be about. What do we do when the patient can't do 3-point gait? How do we train them? Because they've got, neurological problem. They've got a TBI, that type of an idea. So I'm going to stop recording here.